So after I had RFA, I followed up with my local ENT physician. And when he saw my ultrasound, he was very concerned because it looked malignant.
Yeah.
And it had not looked like that prior to RFA. And so he was very concerned that all of a sudden I had developed this massive, nasty cancer.
Yes.
And I tried to explain to him, that RFA changes the appearance on ultrasound, but it doesn't actually transform the nodule into cancer. Is there even a possibility that a nodule could go from benign to malignant once it's been ablated?
Time will tell. I don't think so. We
Uh-huh.
don't have or any studies, that people that had RFA, especially from, the countries that did it, Italy and South Korea and, Brazil, there's no data that things getting transformed. First of all, before you do any RFA, you have two benign nodules. And
Right.
benign nodules, no, when we do things, it has to be done the right way. That's what the American Thyroid Association, agrees. Two benign, we should not even do another biopsy. You have two encounters of two well, sampled, the nodule has been sampled very well, so there's no need even to continue, watch, on that. So that's number one, unless it has significantly increased in size or something. So yes, yeah, so that's the first question. So it's benign; it should not change into cancer.
Mm-hmm.
The ultrasound, it will change completely. Especially the first months or two, you're gonna look really hypoechoic, darker, with white speckled areas, because I see them, it looks very odd, and that's what scared people. I would be scared, if I don't know, if I don't know you have RFA and you come and I scan you, and it's like, oh, that's a very suspicious nodule. But yes, the ultrasound changed completely. But again, I agree with you. It doesn't mean it's got worse. Plus, gonna shrink. So tumors, they're not gonna shrink. They're gonna continue on the rise. And the most important thing, once you do the RFA, you have to keep an eye on your thyroid in general. And the lymph node surroundings, and make sure you're not getting worse. In any other directions. That's why also when I get a patient that's very interested in RFAs and I talk to them, but also when I'm scanning them, I found this nodule, that looks suspicious, which is smaller, but in the future it could turn in something. I have a patient, she was very, 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 she wants RFA to be done in the big nodule, but she wasn't aware that there's a one which doesn't look right, on the top of it, and no one has mentioned that. And I biopsied that, because I know the big one is benign, but this one doesn't look. It comes back atypical or iffy. So I told my patients, maybe RFA is not the right thing for you, because I don't want to do an RFA and 2 years later you're going to end up with surgery because there's a cancer could be starting on this small one. When you pick your patient, you have to be honest and be open with your patient, discuss everything with them, and tell them what from your opinion what the best decision for them. It's not going to harm me doing the RFA, but it's going to harm her in the future, for that other nodule, because it's not the best option for her at that point, until we figure out this atypical or iffy nodule is gonna, get into cancer or it's gonna stay like that. Because atypical follicular cells or the Bethesda-3 or the indeterminate, they can stay like they are, but also they can evolve into these things. But benign, with all the criterion, all my best of knowledge, you should stay benign.
That's a really great explanation. Yeah, I had already had 2 benign biopsies done. So the statistical likelihood of that nodule changing just because I had RFA is insignificant.
It's a thermal induced injury. Body should be able to clean it up, because it's one time. We're not banging on this nodule with heat every day, so that's like when things sometimes get like worried, like. And again, you keep an eye, like you said, for yourself. It went down, it's going down, it's going down, so it's clinically you're improved with, the ultrasound. Yes, it may not be helpful, but now I think after 2 or 3 years you can look at your thyroid nodule and see like if it's going down. And you may have calcification too, which makes people worry. It's okay, it's benign calcification.
That's a typical concern that patients have. They say, oh, I have calcifications. Does that mean that I have cancer?
It's one of the criteria, but it's not the only criteria. And I never did a biopsy after RFA, so I don't think I will, especially if it's my patients. I'll just keep an eye on it. And I have encountered with biopsies, fine needle aspiration biopsy. When I do it in patients, sometimes, as explained to you, some of these goiter nodules or benign nodules, they're crumbling. Once you put the needle, they can infarct. Infarct means they just crumble and die in themselves. Like they come back in 2 years. It's like, oh, there's a new nodule developed and it has calcification. I look, where the nodule I biopsy? It's not there. And what appears that these nodules that I biopsied just got infarcted and got dystrophic calcification. And it just looks different, even after a fine needle aspiration biopsy, but it depends from a nodule to a nodule. You can get this calcification after the biopsy. So not just the RFA cause that calcification or change. Sometimes a fine needle aspiration biopsy can do that, which I have seen a lot, but maybe 5% of this, like, because I have patients, they do an ultrasound a year or two and they come, it's like, oh, there's a new nodule, but I had it twice in my patients, and I do the biopsy on the dystrophic calcification or the weird new nodule that they found, and it's just benign because it just the tube or the coffin of the nodule that we biopsied 2 years ago.
The coffin. That's a good way to describe it.
Yeah, your body just, trying to help you.